Assalamu alaikum and welcome to the new lecture on Angina Pectoris. I am Shaykh Muhammad, lecturer in the Department of Pharmaceutics, Faculty of Pharmacy, University of Sindh. So this is the outline of the lecture. Firstly, we will be discussing ischemic heart disease. Then we will be going for the Angina Pectoris, the symptoms of Angina Pectoris, types of Angina Pectoris. Then we will be discussing acute coronary syndrome, myocardial infarction, and finally we will be discussing the treatment of Angina Pectoris. So before going into the details of Angina Pectoris, firstly we will discuss ischemic heart disease. So what is the ischemic heart disease? It is a group of clinico-pathological syndrome that occur due to imbalance between oxygen supply and oxygen demand. So in ischemic heart disease, there is more demand of oxygen by the heart, but there is less supply of oxygen to the heart. And why this happens? This happens because maybe due to certain pathological condition, less amount of blood is supplied to the heart. Now, when less amount of fresh blood is supplied to the heart, there will be less supply of oxygen to the heart, and eventually there will be less supply of energy to the heart. Now, when there is less supply of energy and less supply of oxygen, there will be also the accumulation of the metabolic waste. This will result into the damage of the tissues and necrosis of the tissue that we called as the ischemia. So eventually we will call it ischemic heart disease because of the less supply of blood, there is less supply of the oxygen to the heart. Now we will discuss about angina pectoris. The angina pectoris has been derived from two words. Angina, that means strangling, and pectoris, that means chest. Now, the angina pectoris means strangling or the congestion into the chest. And medical, we will say that chest pain due to the ischemic heart disease. We have already discussed into the previous slide what is ischemic heart disease. In ischemic heart disease, there is less supply of blood to the heart. Eventually, there is less supply of oxygen and there is ischemia of the heart muscles. And eventually, there will be pain to the patient. So, now we can define angina pectoris as characteristic, sudden, severe, crushing chest pain that may radiate to the neck, jaw, back, and arms due to the impaired supply of blood to the heart. The angina pectoris is #1 cause of death in both males and females. Now this diagram shows the pain caused by angina pectoris in different parts of the body. The darkened purple area shows the pain radiating into the different parts of the body. Along with the pain radiating in the chest and arm, the patient may also feel dyspnea and atypical symptoms such as indigestion, nausea, vomiting, or diaphoresis may also be present. Now the types of angina. The angina may be classified into different types based on type of blockade, that how the blood has been blocked, blood perfusion, how much amount of the blood has been supplied to the heart, and the duration of the symptoms. Now, as earlier discussed, angina is due to the less supply of oxygen due to the less supply of the blood. Now, why this less supply of the blood occur to the heart? Now, this may occur due to the blockade of the coronary artery. Now, there are two pathological conditions for the blockade of the coronary artery. #1 is the plaque and second is the spasm. In the plaque, there may be any thrombus, embolus, or any cholesterol plaque present into the coronary artery that will be causing partial or complete blockade of the blood supply to the heart. While into the spasm, there will be vasoconstriction and less supply of the blood. The angina due to the plaque has been further classified into the two types, is stable angina and unstable angina based on to the duration of the symptoms. Into the stable angina, there are no symptoms when the patient is at rest and there will be symptoms when the patient is working. While into the unstable angina, the patient may be having the symptoms while at the rest. The angina due to spasm is also called as the vasospastic angina. Now we will be going into the details of stable angina. Stable angina is also known as effort-induced angina because the symptoms of stable angina only appears when the person is doing any work. There are no symptoms onto the patient when he is at rest. The stable angina is also known as classic or typical angina because it is the most common form. It is usually characterized by a short-lasting burning, heavy or squeezing feeling in the chest. The symptoms of stable angina can be relieved just by taking nitroglycerin. The stable angina is classified between stable angina and myocardial infarction because its symptoms are more than stable angina and less than myocardial infarction. In unstable angina, chest pain occurs with increased frequency, duration, and intensity and can be precipitated by progressively less effort. Any episode of rest angina longer than 20 minutes, any new onset of angina, any increasing angina, or even sudden development of shortness of breath is suggestive of unstable angina. It is a form of acute coronary syndrome. Now we will go into the details of acute coronary syndrome. The acute coronary syndrome is an emergency situation. In acute coronary syndrome, there is blockage of the blood vessels that supply blood to the heart. Now that blockade into the supply of blood to the heart may be due to the rupture of atherosclerotic plaque, or there may be partial or complete thrombosis of a coronary artery. In most of the conditions, the disruption into the supply of the blood is due to the damage of the atherosclerotic plaque that is present onto the blood vessels. Now when then atherosclerotic plaque is removed or damaged or displaced, there will be damage to the blood vessel and there will be accumulation of the platelets and there will be coagulation. That will result into the blockage of the blood vessel and there will also be vasoconstriction and eventually less amount of the blood will be supplied to the heart. Further, if there is a thrombus that is blocking a blood artery and it is completely or mostly blocking the blood vessels, the supply of the blood to the heart will be blocked. And eventually, when there is blockage of the supply of blood to the heart, there will be less oxygen going into the heart, there will be less energy supply to the heart, and there will be less carrying of toxic substances from the heart, and eventually there will be necrosis of the cardiac muscles, and this we will call as the myocardial infarction. Now when there is a myocardial infarction, there will be increased serum levels of certain biomarkers such as the troponins and creatinine kinase. The acute coronary syndrome may present as ST segment elevation myocardial infarction, non-ST segment elevation myocardial infarction, or as a unstable angina. If a person is having myocardial infarction, he might have different changes into the ECG. Now if you see here, there is a normal ECG where there is a P wave, then there is a QRS complex, and there is a T wave. Now in ST elevated myocardial infarction, there is elevation of the wave in between the S and the T portion of the ECG, as shown by the raised arrow. In non-ST elevated myocardial infarction, there may be ST depression or there may be T inversion. The vasospastic angina is also known as Prinzmetal angina. It has uncommon pattern of episodic angina and these symptoms may occur at rest. This is due to the coronary artery spasm. The symptoms are caused due to the decreased supply of the blood due to the vasoconstriction. The symptoms of the prismatal angina may respond to the coronary vasodilators such as the nitroglycerin and calcium channel blockers. Here is the list of different drugs that can be used in the treatment of the angina pectoris. The drugs may include the beta blockers including atenolol, metoprolol, bisoprolol and propranolol. Calcium channel blockers including two classes, the dihydropyridine that includes the amlodipine, nifedipine and felodipine, the non-dihydropyridines, diltiazem and verapamil. The nitrates including the nitroglycerin, isosorbate dinitrate, isosorbate mononitrate. The sodium channel blockers include the ranolazine. The treatment goal in angina pectoris will be to make a balance between cardiac oxygen supply and demand, and this can be done by affecting the blood pressure, venous return, heart rate and contractility. We have different agents for managing these different physiological conditions. The beta blockers act by blocking the beta 1 receptors on the heart and thereby decrease heart rate, contractility, cardiac output and blood pressure. So they thereby decrease the myocardium oxygen demands during working and at the rest. They also reduce the frequency and severity of the angina attacks. They increase the exercise duration and tolerance in patients with the effort-induced angina, or we call it the unstable angina. They also reduce the risk of myocardial infarction in patients who have already gone through myocardial infarction. The metoprolol and atenolol are more preferred beta blockers because they have more selective action onto the beta receptors present onto the heart. However, at higher doses, all the beta blockers are non-selective. The propranolol should be avoided in patients with severe bradycardia and asthma. When the change of the drug is required and we need to stop the beta blockers, the stoppage of the drug should be carried out through dose tempering within 2 to 3 weeks because this will avoid the risk of rebound angina and myocardial infarction. The calcium is required for the muscular contraction, and when there is ischemia, the more calcium influx is required because there is depolarization due to the hypoxia. Now, because of this ischemia, hypoxia, the several enzymes are activated and they cause more energy consumption, and this will more worsen the ischemia. There are two classes of the calcium channel blockers that are used into the treatment of the angina. Number one are the dihydropyridines that include the amlodipine and nifedipine. These are basically arteriolar vasodilators. These cause the vasodilation of the arteries that supply the blood to the heart, and eventually there is more supply of the blood to the heart and the demand of the oxygen will be compensated. They have no effect onto the cardiac conduction, so there will be no effect onto the rate of contraction of the heart. Because of their mechanism, they are more indicated, more preferred into the vasospastic ischemia or the prismatal angina. The nifedipine is also available into the extended release formulation. The non-dihydropyridine include the verapamil and diltiazem. The verapamil causes the slow AV conduction. So when there is slow AV conduction, there will be slow movement of the current from the atria to the ventricles, and eventually there will be decrease into the heart rate, there will be decrease into the contractility, and eventually the blood pressure will decrease and oxygen demand will also decrease. It has greater inotropic effects than amlodipine but is a weak vasodilator. However, diltiazem also slows AV conduction and is also coronary vasodilator. So diltiazem has both of the effects. It's also causing the vasodilation as well as it is causing the slowing down of the AV conduction, and eventually heart rate and blood pressure will be decreased. The nitrates are one of the widely used agents for the treatment of the stable, unstable, and vasospastic angina. They cause reduction into the myocardial oxygen demand and thereby relieve the symptoms of the angina. The nitrates have a difference in their onset of action and rate of elimination. Like nitroglycerin has 1 minute of the elimination, and while the isocyanide mononitrate has 30 minutes into the elimination. Their side effects include the headache, postural hypotension, flushing, and tachycardia. So finally, sodium channel blockers that are used in the treatment of the angina pectoris. The ranolazine is one of the widely used sodium channel blocker. It inhibits the late phase of sodium current, improving the oxygen supply and demand equation. Inhibition of the late sodium induces intracellular sodium and calcium overload, thereby improving the diastolic function. So less the sodium is coming inside the cell, eventually there will be more time that the heart will diastole and properly pump the blood, and this will also decrease the workload and calcium and the energy demand by the heart. Nolozine is extensively metabolized in the liver, mainly by the CYP3A family and also by the CYP2D6. It is also substrate for the P-glycoprotein. So any of the substances that are inhibiting or increasing the effect of the P-glycoproteins should be used carefully. Its side effects include the constipation, headache, edema, dizziness, and QT prolongation. So if the patient is also suffering from the arrhythmia, these drugs should be used very carefully and their ECG must be observed. So this is all about angina pectoris, and thank you very much.